My talk is more medical management. It's usually not done by us, and it's mostly by the metabolic bone team. And I would like to acknowledge the contribution of my colleague, Dr. Arundel, is a metabolic bone disease specialist at Sheffield Children's. And Dr. Darko has already mentioned about the OI, and we know the classifications and the severity of the disease. So, what is the musculoskeletal implications of OI? So we are worried about, as an orthopedic surgeon, of fractures, of deformities, and subsequently it affecting the mobility. So what are the treatment principles? It requires a coordinated multidisciplinary approach which consists of physical therapy, surgical interventions, and medications. So what are the core team at Sheffield we follow is the physicians who use drugs to either strengthen the bone, reduce the bone pain, and also for the associated medical problems. The surgeons who look after the long bones, the spine, the skull base, and also involve the dental team. And then there are the therapists and the nurses who coordinate all these activities, improve muscle strength and function, and also for the social and educational needs of the child. So, like I alluded earlier, the overall goals are to maximize function, minimize disability, allow social integration, relative independence, and best possible degree of mobility. So the medical management goals are to reduce bone pain, because most of the children with OI have a lot of bone pains. And children with especially type 3 OI, they have very severe rates of fractures, to prevent that. And also subsequently to prevent and correct bone deformities, especially of the long bones and of the spine. And we do get baseline invaginations as well. And subsequently, this improves mobility and function. The orthopedic goals and management will be alluded to by my colleagues. They are to reduce, to correct the deformities and improve the mobility status. Post 1998 in Sheffield, the medical management of OI was done using pamidronate infusion, and they also started the team approach to management of OI. And pamidronate was shown to increase the improve the quality of the bone, and which subsequently helped the surgeons in doing surgeries to correct the deformities. So they noticed denser bone but with narrow canals and some delay in fracture healing. So what are the main medical treatment in OI? And it's basically bisphosphonates, and they are basically stable analogs of pyrophosphates and are potent inhibitors of bone resorption and bone turnover. So what are the results of bisphosphonates in osteogenesis imperfecta? They show an increase in bone mass, basically the cortical and trabecular thickening. There is a denser bone, but which subsequently narrows the canal. There is some evidence of delay in fracture healing, and you do get unusual fracture patterns like subtrochanteric or basicervical. And it behaves like a marble bone disease or osteopetrosis. This is the same slide depicting the same effects. So if you look at these X-rays, this is a child on the basic baseline. You can see collapsed vertebrae, and after bisphosphonates, the spine looks better, and in the subsequent follow-up at 5 years, it looks almost near normal. So in Sheffield, we start treatment as early as possible, basically at the time of infancy. And the bisphosphonates we use in IV practice, in the earlier days it was pamidronate, but now we have switched on to zoledronic acid, and it requires a high dependency unit monitoring for infants because they can cause problems, and a multidisciplinary team is required, and also a shared care. So pamidronate is administered intravenously in cycles of 3 consecutive days at 2 to 4 months interval, It's usually 4 to 12 milligrams per kg per year, like I mentioned, in 4 to 3 cycles. The smallest effective dose should be used with careful monitoring of vertebral geometry, long bone fractures, and bone mineral density before initiating a new cycle. So the pamidronate comes as a lyophilized powder. It's used intravenously. The formulations are either 30 milligram or 90 milligram per vial, and it should be administered as usually the patient is admitted in the hospital for 3 to 4 days, and usually gets a 4-hour intravenous infusion. In patients less than 1 year to 2 years, it should be administered 0.5 milligram per kg per day on each of the 3 consecutive days every 2 months for a year. And children over 2 years but less than 3 years, it's 0.75 milligram per kg per day on each of the 3 consecutive days and every 3 months for 1 year. And children from more than 3 years to 17 years of age, we administer up to 1 milligram per kg per day on each 3 consecutive days for 3 to 4 months. What are the short-term and endocrine effects of pamidronate? There is a decreased serum calcium concentrations, increased parathyroid levels, increased 1,25-dihydroxy vitamin D levels, and decreased urinary excretion of type 1 collagen degradation products. Adverse effects of pamidronate: you get an influenza-like syndrome like fever, myalgias, malaise, rash and vomiting following the first infusion. We have seen that it's unlikely to occur with subsequent doses, but with some children we do get them frequently as well. There is some unexplained rapid weight gain that may interfere with rehabilitation. It can cause uveitis. This adverse effect resolved with discontinuation. I'll just run through because I'm running short of time, I think. And it causes respiratory distress and in younger children, so they require a HDU management. Zoledronic acid, this is the one we use now in most of our children. It's about 0.025 to 0.05 milligrams every 3 months in the first year, followed by every 4 to 6 months as required. And this is also given as an IV infusion. And it can be given as a rapid infusion, 30 intervention with a lot of pre and post saline infusion as well. Or coming to risedronate, this is a new molecule which we have started now in older children, especially the children who have completed IV, and this is given as an oral preparation, and it is found to be as effective as zoledronic acid, but it has some upper GI effects. These are some of the studies which have shown the effectiveness of risedronate, and these are the X-rays which show the difference with the bone quality once risedronate is given. Side effects of bisphosphonates, like I mentioned earlier, is acute phase reaction, hypocalcemia, GI upset, myalgia, rarely nephrotoxicity, anterior uveitis, scleritis, and transient decrease in lymphocyte count. It can also affect the growth, affect bone remodeling. It is known to cause some amount of osteonecrosis of the jaw. It is contraindicated in pregnancy, and it can sometimes affect osteotomy healing. So we need to plan when to give it when we are planning any surgical corrections. When do we start it? When we have confirmed the underlying diagnosis and when you know that it is going to benefit the patient. But and it has to be discussed with the family and the whole team. And you stop it if there are any side effects and in pregnancy. And between starting and stopping, you need to measure the serum and urine biochemistry, vitamin D levels, calcium intakes, regular bone densitometries, and lateral spine imaging. Limitation of the medical treatment is it's not directed at the underlying problem or the cause. It just improves the architecture. So it is dealing with some consequence of the disordered matrix, but not hypomineralization. So, and it is an anabolic agent. You do give supplements of calcium and vitamin D along with it. There are some experimental therapies which are still under evaluation: growth hormone, cell replacement, and gene therapy. Just a short talk on whether bisphosphonates influence surgical management. Yes, it causes adolescent fractures which are unusual, like this one, subtrochanteric, or this is a study which was done at Sheffield, which shows on the right side normal pattern and the one on the left side with bisphosphonate therapy, the fracture patterns. In summary, I would like to say is the benefits do seem to outweigh the risks, and it changes the pattern of femoral OI. But the questions are, when do we start and how long we continue? Whether we give treatment holidays, and what are the sites of osteotomies? Thank you.